King Henry George Lecture. My name is Hong Nguyen, a faculty member in the Economics and Finance Department. Before I turn this over to Professor Balagosian to introduce our distinguished speaker this afternoon, let me mention a few things. Now, the lecture will be about an hour, and then there will be a 15 minutes or so of Q&A at the end. There are posters related to the theme of AIDS that are outside. So if you haven't had a chance to view them, then you're welcome to do so after the lecture. For the ODE dinner guests, there's a reception in room 405. So if you go out of the doors and I guess keep going straight, 405 is to the right. So the reception will be in room 405. The theme for the posters outside is, again, AIDS, women, and the global economy. And they've been put together by a group of students working in conjunction with some faculty members, specifically Professor Zanzana and Professor Moore. Last but not least, let me, on behalf of the Economics and Finance Department and the Economics Honor Society, I'd like to thank Janice McAdam, the administrative assistant to the Economics and Finance Department, and also the officers of the Xi chapter of ODE, especially Nick Caselli, who has done a wonderful job in helping put together this event this afternoon. So with that, let me turn over to Professor Balagosian. Thank you.
Thank you, Dr. Nguyen. Ladies and gentlemen, good afternoon. Welcome to our 21st Spring Annual Lecture Series, Henry George Lecture Series. Before I introduce our special guest, I would like to say a couple of words about this series. So, annual Henry George Lecture Series program is made possible by the continuous financial support of Robert Schackenbach Foundation and brought to you by Economics and Finance Department at the University of Scranton, as well as the campus chapter of Omicron Delta Epsilon, an international honors society for economics. The Henry George program consists of a fall lecture and a spring seminar. The spring event, which started in 1992, this is the 21st event, is organized around the theme of economic justice and deals with issues such as economic development, poverty, inequality, asset ownership, and taxation. This program is named after Henry George, a 19th century economist and a social reformer. In his great classic work, Progress and Poverty, which appeared in print in 1879, George tried to answer the question of why poverty coexists with abundance of wealth. In today's world, George's quest remains as relevant. His ideas on economic justice continue to inspire social activists, politicians, and researchers around the globe in the areas of social justice, distribution of wealth, environmental preservation, and development economics. And now, ladies and gentlemen, it is an honor and my great pleasure that I'm here to introduce our special guest, Dr. Ann Case. Dr. Case is Alexander Stewart, 1886 Professor of Economics and Public Affairs and the Director of the Research Program in Development Studies at Woodrow Wilson School of Public Affairs. She is also the Associate Chair of the Economics Department at Woodrow Wilson School of Public Affairs and a research associate at National Bureau of Economic Research. In addition, the rumor has it that starting from July 2012, Dr. Case will begin to serve as the acting dean of the Woodrow Wilson School of Public Affairs at Princeton University. Congratulations, Dr. Case. Before joining Woodrow Wilson School in 1999, Dr. Case spent 3 years as an assistant professor in the Department of Economics at Harvard University. Dr. Case received her Bachelor's of Science at the State University of New York at Albany. She was the first in the class of 1980. She earned a Master's in Public Affairs from Woodrow Wilson School of Public Affairs and International Affairs in 1983 and a Ph.D. in Economics from Princeton in 1998. Dr. Case's research interests span the area of microeconomic foundation of economics development, health, labor economics, and public finance. Her recent scholarly interests are economic development, primarily in South Africa, and health issues in developed and developing countries. There is no doubt that Dr. Case is an outstanding scholar. Over the last 25 years of her academic career, Dr. Case has authored or co-authored over 40 academic articles and conference proceedings, as well as 5 chapters in published books. Her academic articles appear in top-notch journals such as Econometrica, American Economic Review, Quarterly Journal of Economics, and the Journal of Economic Perspectives. In 2003, Dr. Ann Case and her co-author, Christina Paxson, were awarded the 11th Annual Kenneth J. Arrow Award for the Best Paper in Health Economics. Dr. Ann Case currently serves as an associate editor of IZA Journal of Labor Policy. She previously served as the editor of the Journal of Development Economics, associate editor of Journal of Economic Perspectives, and Economic Journal. She also sat on the board of directors of the Journal of Economic Literature, American Economic Review, World Bank Economic Review, and on the advisory panel of National Science Foundation. There is also no doubt that Dr. Ann Case is an outstanding teacher. She was the 2011 recipient of the President's Award for Distinguished Teaching at Princeton University. So get ready to listen to a lecture given by one of the top-notch professors at one of the world's best universities. The topic of today's lecture is the economic causes and consequences of AIDS in Africa. I thought to elaborate on the topic a little bit, but then who can do that better than our special guest herself? Ladies and gentlemen, please welcome our special guest, Dr. Ann Case.
Thank you so much, but I have to say thank you for coming, and let's, that was a very warm introduction, and I'm very grateful. Thank you. I'm delighted to be here today. I wanted to start just by thanking the Economics and Finance Department and the Robert Schelkenbach Foundation, Omicron Delta Epsilon, and to congratulate those of you who tonight will be inducted into ODE, which I'm a member of good standing, and the Latin American and Women's Studies for hosting me today. So it's really a pleasure to be here. I wanted to talk to you about 3 related pieces of research, all on the same theme, which is sort of like the causes and consequences of this horrible pandemic that's taken the lives of so many people, and so many of them in Southern Africa. This slide and the next slide come from UNAIDS, who have put together a terrific website that's full of information on the causes and consequences of AIDS. UNAIDS is a organization made up of UN, World Bank, World Health Organization. And they're trying very hard to see what we can do to try to stop this horrible pandemic. About 33 million people worldwide are thought to be living with HIV, and stunningly, 2/3 of them are in sub-Saharan Africa. Now, when you think about the fact that there are 1.6 billion people just in South Asia alone, and 800 million people in all of sub-Saharan Africa, the idea that it's so heavily skewed toward Africa is a reason for some concern. And deaths from HIV, about 2 million annually, a lot of those are people in prime age, which actually leads to a very large number of orphans as well. And we'll be talking about them in just a little while here. Here's also, this is from UNAIDS. Here's a picture of what happened in Africa from 1990, that's the top left, down to 2009, a scant almost 20 years later. And what you see is the crisis deepening, especially in East Africa and in Southern Africa, which is sort of known collectively as the AIDS belt. So you can see the crisis, just the deeper the red, the worse the crisis is in terms of the percentage of people living with HIV. So the first question you might be interested in is, why Africa? Right? And in Africa, this is actually this is a heterosexually transmitted disease. So what we say at UNAIDS all the time is know your local epidemic. So the epidemic in the US, which is either men having sex with men or intravenous drug use, that's not the crisis in Africa. The crisis in Africa is a widespread disease that has affected the general population and is spread through heterosexual sex. Now, why Africa? I mean, it's sexually transmitted, so it might have something to do with number of partners, male circumcision, which we think actually is protective against HIV to some extent, age at sexual debut, how young do you start having sex, and do you use condoms? Right? So those things will all protect you against HIV, but they don't explain why Africa is actually bearing the brunt of this crisis. The number of lifetime partners is about the same in the eastern US as it is in Eastern Africa. Male circumcision is about the same in Europe as it is in sub-Saharan Africa. Age at sexual debut is not very different either. So one hypothesis, which is still controversial but seems to hold some way into this crisis, is to look at overlapping what we call concurrent sexual partnerships. So if one person in a network of people who are having sex with a number of people gets sick, everyone could get sick. Because HIV, it turns out, is a really nasty bug because you're at your most infective before you even feel sick. Because your viral load is very high at the very beginning, then it's going to drop. But if you are infected and you don't know you're sick and you give it to your partners, it can spread very quickly. So let me show you a picture. This is from my friend Helen Epstein's book called The Invisible Cure, which I recommend to you about the HIV crisis. The top panel shows what we would call serial monogamy. I don't always stay with the same partner, but I'm only ever having sex with one person during some window of time. Then I might switch partners, but it's one at a time. Whereas the bottom panel, and I know this is hard to see until you get over a little farther to the right, are people who, I have a boyfriend in the city and I have my husband in the country. My boyfriend in the city may have another girlfriend. So if you have a number of people who are having sex in an overlapping way, if one person gets sick, so let's take January, where you see that little arrow in the bottom panel. In May, the serial monogamy couple, they may have broken off. They both have HIV, but they can only now give it to one more person at a time. Whereas, and you can see by the time you get to August, that originally ill person has given it yet to another person, right? So it's spreading, but it's spreading relatively slowly. Whereas in the bottom panel, when you get to May, the disease has already spread to many people in the network, and even more so once you get to August. And we think that that actually is why it was like dropping a match in a dry patch, why it hit Southern and East Africa so hard, because partnerships look more like the bottom panel than the top panel. Now this is still controversial because it's very hard to get the data you would need to test this. Because it's not whether or not I'm monogamous, it's about what my partner is doing. So you need to not only interview a person, you have to interview that person's partner and find out all the different people that partner is having sex with. And those kind of data are actually sort of hard to come by. So one of the things you could do, though, is try to do what Uganda did, which is try very hard to get people to pull back from their casual partnerships. And when they did that, they began to see some success in bringing down the prevalence rates of HIV. Okay, what else do I want to say about that? Not much. Okay, the premature deaths that are caused by your kin, by your neighbors, by your school teachers, by your parents, have consequences in all dimensions of life, right? So, and now large data collection efforts have begun to let us get some longer run look at what's happening because of this crisis. Whoops. So today we'll talk about 2, possibly 3, depending on how the time goes, consequences. The first one, which is to look at what AIDS might have been doing to the non-AIDS related medical services available in Africa. That grew out of a conference I was at UNAIDS, where people sat around the table and they said, well, what do you think will happen? And if you don't have data, you can make up any answer you want, right? So you can pull out of your pocket some argument that it's going to crowd out the non-AIDS related services, there's going to be cream skimming, that we're going to take the best medical people and use them for HIV, so it's going to be horrible. Or you could say, well, actually, there are a lot of resources now being sent into those countries for medical care. It's possible that things actually might get better. And without data, you can't really answer that question. So I'll show you what it looks like when we actually have the data to actually say something. Then we'll turn and look at what happens to orphans and whether or not orphans are at special risk relative to other poor kids that are also living in these countries. And then if we have time, and this would be a really cheerful note to end on, we'll talk about funerals, right? Because what's happened in Africa now is that, like most parts of the world, it started as an area where people died either really early in life or in old age. And in those cases, really early in life, and this is still the case, simple funeral, traditional blanket, bury the baby, that's it. And in old age, people would have old age insurance that would help to defray the expenses associated with the burial. But if you take that system and then suddenly people start getting sick and dying in middle age, and you don't have the resources to actually continue the kind of elaborate burials you are using for your older people, you can run into quite a lot of difficulty. And if there's time, we'll come back and look at that at the end. And I guess I wanted to also mention at this point, I'll try to, as we go along, talk about all the different methods one could use to try to answer some of these questions and to try to say what's positive and negative about using various things as we go along. All right, and this is basically the series of papers from which this talk is drawn. A lot of them are with my good friend Chris Paxson, who's leaving Princeton to go off to be president at Brown. All right, so the first one is what has it done to medical services? I already talked about that part. To look at this question empirically, what we did was we drew on what are known as demographic and health surveys. These are large, nationally representative surveys in most of the poor world. They're done every 4 or 5 years. They ask a uniform set of questions, so you can actually look across countries over time and answer certain questions with them, and that's what we'll be doing. When you think what's been happening to non-AIDS related health services, well, you wouldn't want to compare, say, brain surgery in Cape Town with brain surgery in Dar es Salaam. That would, the quality differences are so big. But there are sort of simple things you can go look at that we know are important. Like what? Like women receiving prenatal care, like having a trained birth attendant at delivery, children's immunizations. Sort of a straight up and down set of questions you can ask, and we can ask them with these data. And I say, and be largely pre-ART. What that means is pre the arrival of antiretroviral therapy, which we think is keeping people healthier and keeping them alive longer. Our data come from 1988 to 2005. 2005 rollout of these big antiretroviral programs had just started. So that's really not going to be a part of our story here today. The last round of these demographic and health surveys in sub-Saharan Africa actually tested adults for HIV. And the vast majority of people were willing to be tested. So these actually have become probably the best estimates we have of what HIV rates look like in most of Africa. And what we'll do is we're going to sort of age the crisis back so that in 1980, when rates were virtually zero, and then see what happens when they go from zero to whatever number they were at the time of this most recent survey. And I'll show you how that looks as we go along here. We wanted countries with multiple surveys, so we could look at, back in the day, what was happening to women's health care, children's health care, and then today, what does it look like? We have 8 countries in West Africa where the prevalence rates and sexual partnerships, by the way, are also very different. The rates of prevalence of HIV are much lower, and 6 countries in East and Southern Africa, and you can read them: Ethiopia, Kenya, Malawi, Tanzania, Zambia, Zimbabwe. And here, just to give you a sense, are from the lowest levels of HIV. That would be Niger on the left there, and these are prevalence rates by region of the country. The DHS's, these demographic and health surveys, divide the country up into regions, and the HIV rates in many countries are very different between regions. They might be very different in the cities than they are in the countryside, for example. So Niger, Senegal, Mali, Guinea, Burkina Faso, Ghana, Ethiopia, Cote d'Ivoire, Cameroon. Now we're beginning to get some action here. Tanzania, you can see there are 3 regions of Tanzania where the rates are almost 15%. Kenya, where again, there's quite a lot of dispersion between some areas and others. Same is true in Malawi, which has 3 regions, one of which has an HIV rate of about 17%, whereas the low one is down less than 10%. Zambia and then Zimbabwe is just uniformly high rates of HIV. So we're going to make use of that variation here. And then what we'll do is we're going to put it together with, for example, information that mothers tell you about what was true when they were pregnant with their most recent child. So just to give you one example, here's Burkina Faso in West Africa. There was a survey run in 1992-93. It asked mothers about births they had had between 88 and 93. So you can actually say by birth year what was true in this country. Then there was a second survey, 98 to 99, covering births from 94 to 99, and yet another one in 2003 covering births from 98 to 2003. So for every birth year between 1988 and 2003, we have information about that mother, which is what we're going to be using then to say, back in the day before the crisis was really deep, what was true for her health care? Now that the crisis is much richer, what's happening now for her health care? So the health care we're going to look at is whether or not you went for antenatal care, and once you got there, did you have a urine test, which you do for onset diabetes during pregnancy, blood test, mostly these days used to see if a woman is HIV positive, because if she is, 2 drops of nevirapine just before she delivers and 2 drops just after she delivers cuts the rate at which she transmits HIV to her baby by about 75%. Right, so it's really worth having your blood tested if you're a pregnant woman in Africa. Do you have your blood pressure taken? That's something that you have to worry about when women are pregnant. And was your weight taken? And for delivery, and I'll skip this, but I'll say it's also going to be true for this, was there a trained birth attendant at your delivery, which actually is extremely helpful if something happens to go wrong. All right, this is just raw data on the countries where the HIV crisis is deepest in our data set: Kenya, Malawi, Tanzania, Zambia, Zimbabwe. The upper left is whether or not you report that your urine was tested when you went for prenatal care, blood test on the right, lower panel, blood pressure taken, and lower right, weight taken. And you can see that throughout this period, women report worse prenatal visits at the end of the period than they did at the beginning of the period. And this is just in the raw data, right? This is just, and these are nationally representative surveys. So each year you're actually getting some really good read on what's happening. And I can say I don't have a slide on it here for lack of time, but these women continued to go for prenatal care in about the same numbers. It was just that when they got there, less was being done for them. Right? And the 2 upper ones, urine tests and blood tests, that might be because medical staffs didn't want to handle vital fluids. They might have been afraid of their own infection. Or it could be that there weren't as many medical people around to take blood or urine. And to give some credence to that one, having your blood pressure taken, as long as there's a cuff, there's no other expense other than having someone who's been trained to do that work. So our best guess is that there's something about the quality of the medical care that was available for this very important time was falling. And I'll note that weight taken is on a different scale than the other measures. It also, women were less likely to report that they were being weighed, right, when they got there, although those numbers are not like of crisis proportions. If you run regressions and you ask, What happens in a country region if HIV went from 0 incidence to 10% incidence? Then what you find is that the women are 15 percentage points less likely when the incidence has gotten to 10% to report that they had antenatal care. But the urine tests, blood pressure, weight taken, all deteriorate in high HIV regions. And in fact, in West Africa, many of these indicators have gotten better, not worse, over the period. It's in the high HIV countries, which actually started with better healthcare systems, that things have gotten much worse. And just with immunizations, the rates look very much the same, meaning going in the wrong direction. Women going from a 0% incidence to 10% are about 60 percentage points less likely to report that their child was immunized against polio at birth. And that's not with a needle. So it's not as if, well, maybe I'm just afraid the needle might be infected and my baby will be too. Because at birth, what they do is they just put drops in the mouth. All right, so these other ones too, about 20 percentage points less likely to have their kids immunized against polio, measles, BCG, which is about tuberculosis, and diphtheria, pertussis, and tetanus. That's the last one. So these healthcare systems have gotten a lot worse. I can't really tell you why. I mean, I'm trying to encourage some of my graduate students to start doing field work and try to dig in and find out, what is it? Is it the fact that the beds were being taken up by people who are ill with HIV? Is it the fact that the medical people became sick themselves and left? Is it the fact that there's just no money to provide these services, given the services that have to be provided to people who are dying of AIDS? And until we know that, we're nowhere. So, I mean, we can report this. This is sort of, these are what the facts look like. But why these are the facts is something that we still need a lot of work done on. So I just talked about those things. Okay, the $64,000 question is really this, which is, will the arrival of antiretroviral therapies actually make things better? So we're now almost at yet another round of these demographic and health surveys that would have been in place after antiretrovirals have been diffused in Africa, and it's possible that we may be able to report better news, but that's still to be seen. Okay, so I'm going to move now to the second thing I wanted to talk about, which is going to be about orphans. So there are about 43 million children in sub-Saharan Africa who have lost at least one parent before they're as old as you guys are now, right, before age 18. About 12 million of them are thought to be AIDS orphans, and then you might wonder, well, does that matter, like why their parents died? And I'll tell you that AIDS orphans are significantly more likely than other orphans to be maternal orphans, to have lost their mothers. And they're significantly younger when their mothers die than are other kids who lose parents. Those two things I'm hoping to argue convincingly for you lead children to be at risk of worse outcomes. It turns out having mom there, especially at early ages, can be extremely important. UNAIDS estimates that the number of orphans has increased by 1/3 since 1990. So are orphans at special risk? And this may seem, I like to, with my students, say, this is kind of what I consider a mom question. Like if I tell my mom what I'm working on, she's going to say, do we really need research to tell us whether or not these kids, don't we know those kids would be at special risk? But the truth is, in policy circles, there's a lot of pushback on the idea that orphans are different from any other poor child. And one version of this argument goes like this. Everyone in this community is affected by the pandemic. Why should orphans be selected out for special treatment? And so I'm hoping just to show you some facts about what happens to them relative to other kids and let you see what you think. So the first of these papers, again, uses these demographic and health surveys, these nationally representative surveys. At this point, we had 19 surveys coded up and from 10 countries in sub-Saharan Africa. And we tend to see a uniform pattern across the surveys. And I'm about to show you what are really the results of, again, from regressions, which are probability of enrollment in school is the left side variable. And we're going to regress that on, complete set of indicators for kids' age, and an indicator if the child is an orphan, and in some cases, relative to being a non-orphan, and other regressions where we'll take all non-orphans and put them with kids who have lost their moms, but that we know their dad is alive, all kids, and then another regression, non-orphans, and then all kids whose moms are alive, but dad is dead, and then non-orphans against kids who we know have lost both their parents. And we use enrollment here because it's a snapshot, and we want to say what's true for these kids today. They may be fallen behind in school if they were taking care of a sick parent, but the question is there going to be any kind of bounce back after the parent is dead? So what we find is actually children who lose a father are at significant risk for living in a poorer household. That's true throughout sub-Saharan Africa. But that doesn't actually put them at risk for not being enrolled at school. It's the loss of a mother that puts the kids at risk of being of lower school enrollment, and double orphans are actually at the largest risk. They're also least likely to be living with a relative, more likely to be living with non-relatives, and that alone tends to put kids at risk for poor schooling outcomes. So these are, I know we come from different backgrounds, so just listen to what I say if it's hard for you to interpret what's on the screen here. These are the point estimates on the indicator that you're an orphan in this regression of whether or not you're enrolled in school. And these are point estimates from regressions run in every survey, so it's Ghana 93, Ghana 98, Mozambique 79, Zimbabwe 99. So a different regression for each survey to allow for the fact that there may be cultural differences in how people respond to this, and so it might be true that what happens in Kenya isn't what happens in Mozambique. But what we see is that being an orphan of any type, you're at significant risk for lower enrollment relative to non-orphans. That's what the upper left panel means. The right side, those are the maternal orphans run in contrast to non-orphans. And what you see is a fairly uniform pattern there as well, that kids who have lost their moms are significantly less likely to be enrolled. Those little bars up above and below give you the confidence intervals. So when those don't reach the 0 mark, that means it's a statistically significant difference. Paternal orphans are a little bit up, a little bit down, and then you can see double orphans seem to face particular risks. Okay, so what puts children who have lost their mothers at risk? Well, kids, it turns out, in Africa who have lost their mothers are a lot more likely to become what are known as virtual double orphans, meaning they don't live with their father and their mother is dead, so they have no parent in the household. So that is one thing that seems to be putting them at risk. There might be scarring. They may be less school ready after their moms die. And so the families or the households don't send them to school because their executive function is up to being in school. Losing your mom is oftentimes losing your school champion. She protected the school fees. She made sure that you got to school. And the orphans may actually face some discrimination in the households that absorb them. And largely in Africa, households do absorb children. Kin do take care of kin. The question would be, though, do they treat those kids the way they treat their own kids? My hard-headed economist colleagues would say this could easily just be spurious correlation. And I'll try to say this with a straight face, but it's a little hard for me. If you lose your mother to AIDS, if she was a crummy mom, and so you're probably not going to be in school anyway, right? So it has nothing to do with her death. It's just the fact that you're just you come from lower quality stock, right? So you weren't going to be in school anyway. And the truth is, these are cross sections. They're nationally representative. They're large. That's great, but they can't actually compete against longitudinal data that follows people through time, and we'll turn to that in a minute here. But I'll tell you what we did. We tried to do to try to get a little bit around this idea of spurious correlation, which was we looked at where these children were living. Were they in a household that was headed by the parent who survived? Were they living with a grandparent head of household? Were they living with other relatives head of household? Or were they living with non-relatives? And this was kind of to try to make use of what's known as Hamilton's rule, which has to do with the fact that you may feel more altruism toward people with whom you share more genetic material. So you might think that parent more protective than grandparent, grandparent more protective than other relative, more protective than non-relative. So, and when we do that, okay, so I don't know if I have another slide, no. All right, so when we do that, what we find is exactly that order. that if you go to live with your grandparents, you're at little risk for non-enrollment, but it's not as bad as living with an other relative, which is not as bad as living with non-relatives. And so this double orphan problem seems to be because you're significantly more likely to be living with someone with whom you're not related. Now, of course, my hard-headed economist colleagues would say, well, you know, Granny might walk in and say, well, that one looks smart, I'll take that one home with me. You know, and then the next round of people who get to pick kids are going to be the other relatives. And so the non-relatives taking in kids, they're taking in the kids who are the troublemakers. I mean, so you can't argue that that's not what's going on here. So let me show you data from a longitudinal data site in South Africa where we've been working since 2000. Okay, so I'm going to show you a different kind of data set. So what we had been looking at were these snapshot cross-sectional data sets. Now we're going to follow people through time. And that's very powerful because it's almost like a soap opera. You can see what happens and then what happens next, right? But it is only one part. It's one corner of Zululand that I'm going to show you data from. Right, so it might be special in that way. What's nice is a lot of the patterns we saw in the demographic and health surveys we're going to see here as well. So this is an area about the size of a county in the eastern part of the US, about 2 hours north of Durban on the east coast of South Africa. It's about 11,000 households, and it's about 100,000 people. About 3/4 of them are living in the field site at any one time. There's a lot of migration for work that goes on from this site. It's not a census, although I'll oftentimes call it a census. It's really technically a continual registration system. So twice a year, every homestead is visited, and information on births, deaths, migration, change in marital status is collected. So it's kind of like this living, breathing data set. They've let us go in 7 times since 2001 to collect data on socioeconomic status of these households. So you can think about doing work on the two-way links between health and economic status. There's a women and men's general health module. We won't talk about that. And they're doing HIV testing there too. We won't really talk about that today. What I will show you are results from the first 2 rounds of socioeconomic data. One was collected in 2001, one was collected in 2003 and 4. We're now in the process of analyzing all of the data that we've got through the whole first decade of the 21st century. But for today, this is the data that I'm going to show you results from. So here's the snapshot of when surveillance began in January 2000. The red line are paternal orphans, the blue line are maternal-only orphans, and then the black line are double orphans, so both parents are dead. Like the rest of Africa, it's still more likely to have lost your dad than to have lost your mom. But losing your mom is not uncommon here. And then this is kind of the sad news. Between 2000, that's the lower blue line, and 2004, this is the fraction of kids at each age who have lost their mothers. So if you stare at that for a second, you'll see that in 2000, just under 5% of kids aged 10 would have lost their moms. But by 2004, just 4 years later, almost 10% of 10-year-olds had lost their moms. Right? So this is actually just stunningly bad. And if you look over time, which we haven't analyzed all the data, but I pulled these out to show these to you. These are the first 5 waves of the socioeconomic module, just what maternal orphanhood would have looked like. That rotation shows you the crisis deepening, right? So you can actually see with your eyes the number of kids who are living without a mom. And one of the reasons for that is that women in South Africa will have a first baby very early. Then there's this yawning stretch where they'll not have another child. And then in their late 20s or their early 30s, they'll have a second child. So a lot of these deaths of mothers are young mothers who become ill and die in their 20s even. But what's really nice is you think, when will there be good news? Well, from 2007 to 2010, that line doesn't budge. And that's because in 2007, antiretrovirals began to appear in the field site in a big way. So it didn't stem the crisis. It's not as if that line is rotating back down towards 0, but it didn't get any worse, right? And so we think that's actually something that looks a lot like good news. With paternal orphans, it's the same thing. It got worse until 2007, and now not. So that's, for us, evidence of ART on the ground and what it can do. Okay, relative to other children the same age, Maternal orphans are about 25 percentage points less, or no, about a quarter of a year behind in school. Paternal orphans, there's a little bump, but that's not statistically significant, and double orphans look just like maternal orphans. And I can tell you in this field, I know why those two look so much alike, and it's because the fathers really are not on the scene. Like a large fraction of them are dead, or they've never been part of the registration system. They don't live with a mom. And so the kids aren't living with their dads when their moms die. So they really are double orphans. Probability of being enrolled for maternal and double orphans is quite high. About 2 to 2.5 percentage points less likely than other kids the same age. And less is spent on their schooling. Indeed, about 20% less is spent on the schooling of maternal or double orphans relative to non-orphans. And in South Africa, the expenses associated with going to school historically have been quite high. It's school fees, it's uniforms, it's books, it's transportation. So the idea that less is spent on them is also clearly able to be seen in the data. Okay, what we find, and I don't have any like numbers to show you, you'll be relieved to know on this part. What we find is that children are not behind until their mothers die, and then they begin to fall off the rails. So, because we can actually document that in the data. They're on course, they're on course, they're on course, their mom dies, and then suddenly they're less likely to be enrolled, and the longer they're not enrolled, the farther behind they fall in school. Is this causal? Does it mean mom's deaths caused them to do this? This is temporal evidence, that's all it is. But it's probably as close as we'll ever get to causal evidence in this particular case, right? And this is not the kind of thing you're going to go out and run a randomized controlled trial on, right? Like you think about like, okay, you kids, we're gonna wipe out your moms, all right, so. All right, is there bounce back with time? Is it possible these kids need to just a little bit of time and then they will recover? We see no evidence of bounce back. It looks like these kids, and if they start going off the rails at a very early age, they fall further and further behind, and they don't actually, they're not able to catch back up. Are there other long-term consequences of early maternal death? We now know a lot about these kids, some of whom lost their moms in 2001 or 2002. So 10 years later, they're starting to try to make connections with the labor market. They're starting to have sexual relationships. They have a lot more adult-like outcomes, and we're going to be able to see whether these problems that happen to, things that were bad that happened to them in childhood continue to follow them around in adulthood. So that's what we're working on just now in this field site. Okay, just a couple of things. My friends at UNAIDS drive me crazy because they want this to be a girl problem. And so they want it to be, it's not orphans, it's just girl orphans because they're the ones who have to stay home and take care of the family after mom is dead. And that's not true. It's equally true for boys and girls. Not South Africa because boys and girls go to school at the same rates. In most of the rest of Africa, boys are more likely to be enrolled in school than girls are. And I think that's a shame and that's a sin, but that difference is exactly the same for orphans as it is for non-orphans. So it's not the orphaning that's making that happen. It's some other thing that we're going to have to deal with. Okay, so which of these, without knowing more about the mechanisms, we don't know which of these policies would be the most helpful. Special treatment for orphans, right? Do you want to actually have special crisis centers for them, special like social services that come in and help them? We don't know, because we don't know if this is about affect changing, we don't know if this is about executive function changing, and it would be really good to have real data on that so we would know if that would help. Would cash transfers help? Well, it turns out that we can actually look at children who've lost their moms who are living in households with children who have not lost their moms within the same household, meaning that within the same distance to school, the kids who are orphaned are significantly less likely to be enrolled than the kids who aren't orphaned. All right, so maybe that cash might get spread around and a lot among all the kids in the household. We don't know. It's not really possible to know without more work in this area. I tend to be in favor of in-kind educational transfers. You waive the school fees or you offer school uniforms to kids who have lost their moms, trying to just make it that much easier to get them into school. Okay, I think we have, oh good, we have about 10 minutes to talk about funerals. So So institutions that evolve over a very long period of time often do so for many reasons, and funerals, especially as you get older, you will sadly find out funerals evolve for many reasons, and a lot of them are protective. Right? They pay respect to people who have died, they console people who are grieving, they also mark social status of the family. They can knit social fabric within extended families and communities, and they can redistribute some of the resources that had belonged to the deceased, right? So it's all of those are complementary. It doesn't have to be one or the other. And I already said this before the AIDS crisis, we buried young people and very old people, and now we're burying people in large numbers who are dying in middle age. And I should say, in Sub-Saharan Africa, a funeral is as large there as a wedding would be in, say, the US. So it is the most important ceremony. There's nothing more important than sending off the deceased to become an ancestor in really high style. And what happens is your extended family comes and stays with you for as long as they want to stay. And you feed them for as long as they want to stay. And they expect to be well fed for as long as they want to stay. Then there's the coffin and the flowers and the marquee and all the other trimmings. But it's a really expensive proposition. So the Africa Center, which is the demographic surveillance site I was telling you about, allowed us to collect data on funerals and costs about the illnesses leading up to the funerals for all deaths that have occurred between January 2003 and December 2005, so that we could actually try to document what was happening and maybe a little bit on why it was happening and its consequences. I don't have to tell you, if you sink a lot of money into the ground, that money's not there to pay the kids' school fees, right? To actually stake a migrant in the city until they can find work, to do all these things that are actually productive. So we wanted to document the costs, find out how the household made decisions on the funeral spending, and see whether or not there are long-term consequences for households that borrow money. So on average, we found that households spend the equivalent of a year's total expenditure on food and groceries, which is huge. I mean, these are poor people, right? This is huge. Approximately a quarter of those households, the person who died was an old age pensioner, had burial insurance, and that helped to defray the expenses. But when you're dying in middle age, you don't have that kind of insurance. You could, but you don't. It's really interesting. If people in middle age started to buy that kind of insurance, the insurance market would dry up because it would just turn into a death spiral. But for now, it's old age pensioners paying into this burial policy that then pays out when they die. About 25% of households had to borrow money, and most of that's from money lenders with interest rates of upwards of 20% a month, right? So you can really go deeply into the hole if you have to borrow money for a funeral. So then we ask, well, what can we tell about the person who died and the household that might explain why this household spent this much money on the funeral? Because the community expects then wealthier households to have a bigger party. That's part of it. Also, among the Zulus, if you're a man, you slaughter a cow instead of a goat, so that's going to be a lot more expensive than when a woman dies. The older you are, the more expensive the funeral is going to have to be. So we know there are characteristics both about the person and the visuals about the household. Does it look like the household has some assets? Because even a wealthy household will borrow money from a funeral if it looks like they should be throwing a bigger party than they have the resources currently on hand to hold. Then we test this and we find that that's the case. I'll just end with, I'll have a couple more comments here. One is that you could change this. 2 generations ago in South Africa, funerals were not this big. And then suddenly this norm developed about, and instead of people bringing you food, it was expected you would feed them when they came for the funeral, that sort of thing. Swaziland, the king of Swaziland decided he was going to change this. He made 2 pronouncements. The one was the funeral has to be over before the king leaves his door in the morning, meaning it should be a cookie and tea event and not a homebrew slaughter the cow event, right? So that's going to keep down expenses. And the other thing was, if you slaughter a cow, you have to give one to the king. So there's 100% tax on actually having beef at the funeral when a man dies, right? So that's fine. You could think that villages could do that as well. You know, everyone in this village agrees we'll have a simple tea and cookie funeral. But the problem with that is your extended relatives who are coming from Johannesburg, they didn't buy into that. They didn't agree to that. And so there's a lot of social pressure from within your extended kin group not to break this particular model. So this is a tough one. The consortium of churches in South Africa has come out strongly favoring simple funerals, but so far that just hasn't had legs. Now, you do see some signs of change because you cannot do what these people are doing forever. One is now that there's a fancy pants coffin, but that's just for show. And then when it comes time to actually bury the person, it's a pine box, right? So you get some of the trimmings of kind of some American weddings where you get the Rolls Royce to take you to the church. That doesn't mean you had to buy the Rolls Royce, right? So there's some of that happening. But then, okay, and I'll end on this. It's maybe the spending's good. You know, what makes you think this doesn't make them happy? Maybe this makes them really happy. We've all been to households where somebody's mom wanted to show you the wedding photographs again, right? And every time she thinks about the wedding, it gives her positive utility, right? Maybe that's what's going on here. So in a different demographic surveillance site up on the Mozambican border, we actually collected a lot of data to actually look at this question. And what we found was that in households that experienced a death in the last 5 years, there's significantly lower spending in that household today, which makes sense if you're paying back big expenses that you incurred at the time of the funeral. Adults in the household also report more symptoms of depression and anxiety. Children in the household are also significantly less likely to be enrolled in school than children their age. So while there might be positive utility in being able to talk about that wonderful funeral we had where we sent someone off to become an ancestor, it comes at a cost to body and soul. So that's, I think, a perfect, that's all I brought. So I'd be really happy to take some questions. So thank you. Thank you. Yes.
In your research, what's the primary reason for the age prevalence like North
That's a really good question, and it's really also West Africa versus East and Southern Africa. And I think now none of this is settled territory, but I think largely it's about the nature of sexual partnerships. That in West Africa, there's going to be a lot more serial monogamy, and in East and Southern Africa, there's going to be a lot more of these concurrent sexual partnerships that put people at risk. And I think that's partly because in East and Southern Africa, there's a long history of migration for work. Right? There's also a lot of mines. There's a lot of very productive land. So people go to work the land. They go to cities to become. The history of apartheid in South Africa also makes them vulnerable because the logic of apartheid was to stick people out on rocky outcrops of land where they couldn't actually work, so they'd have this surplus pool of labor from whom you could draw when you needed them in the mines or you needed them on the farms. So that's going to make the problem worse. But that doesn't explain exactly why it's also true in Mozambique and Zimbabwe and Kenya and Tanzania. And so we think that possibly the kinds of sexual partnerships that were considered acceptable grew out of the fact that in East and Southern Africa, migration is just such a big part of adult life.
My question is, we are looking at catch-22 based on education or lack of education. All this recreation sex leading to procreation and lack of education lead for more procreation, more recreation and lead to more. What is your thought and the remedy for this problem?
See, it's interesting. I'm really glad to raise this, and I think the answer may surprise you. which is the parts of Africa where the HIV crisis is now strongest are the areas where the education systems worked best. And what happened was then women would stop going into relationships where they would be a second wife. Instead, they were willing to go to the cities and work. Sex before age 20 and having not married before age 20 skyrocketed in those places where girls were more likely to go to high school. And those are the places then and that was before HIV. Then HIV hits and whoosh, those are the places where suddenly it's much worse. Also in South Africa went through its demographic transition before the AIDS crisis, right? So it's actually a country where one of the highest rates of HIV in the world, but at the same time, women literally, as I mentioned, they'll have one child early on who is largely raised by their mother, and then they'll have a second child in their late 20s, which is a very unusual pattern of fertility, but it's not this idea of you know, that there are just all these babies being born. It's actually beyond that. So the education, which is funny, and it's something we're grappling with how to write up our findings on this, because we're not anti-education people, but at the same time, this particular story in Africa seems to be one in which education played a role at the beginning of not being protective. Now that may change. Now that people understand more of the mechanisms, having more education may protect those people, but initially it was part of the problem and not part of the solution. Yes?
There might have been more promising stuff.
So I have not done work on this, but Emily Oster at the University of Chicago's work suggests that that is the case. She wants to also argue that it's partially the STDs that made both sexes more vulnerable to the HIV/AIDS crisis because they already were compromised because of the STDs. Yeah. Yes.
Based on the findings in your research, how has it impacted your views and thoughts on universal health care and how preventative medicine could stem the tide of this pandemic?
That's a really good question, too. In the end, prevention is going to be the cure, right? So I don't have much of an opinion. I don't think this has changed my opinion on the importance of universal health care because I was already a really big proponent of that. But I think that the hard part with prevention is we still don't get it. We don't know what works. We don't know. There's a little tiny bit of evidence that information may make a tiny difference in some groups, in some settings, but we're nowhere yet where we need to be in terms of, especially with young people, how to actually get them to use condoms or to abstain from sex or to, pull back on casual partnerships. I'm sorry. Yes. It's true that my work is largely based in a country that is kind of a first world, third world country, which is South Africa, which is really sui generis, right? So in other parts of Africa, it really could be possibly manipulated, and that would certainly be an issue. South Africa, because it's always, even from its apartheid days, possibly because of its apartheid days, has really good information about its citizens, right? And that's not going to be the case in many of the other poor countries that have been so hard hit. Yes?
Rely on the hope that the government will come and sort of rescue these children, take care of them, more so than the family?
The families really do, being on the ground now for as many years as I have, my sense is that families believe it is their place to take in kin, and that is actually part of their responsibility. In a country like South Africa, which is relatively wealthy, there's a lot of talk about what kind of transfer programs might work best for orphans. There is certainly a lot of pushback against there being a cash transfer for people who take in orphans. And so this idea that the government is somehow going to fix it, I don't think is part of their thinking. That's my personal opinion, but that would be my sense from having been on the ground there for quite a long time now. Oh, yes, in the back.
Thank you. You cited Uganda as a great example of a country that was able to reverse the trend of HIV by, just maybe engaging the citizenry in prevention. One of those was the message of abstinence, which is very strong. The church was very active in asking young couples to abstain, not only that, before marriage, to actually go for testing and be open about their status, and that helps. So there is at least some data there that can be applied towards the question the young man asked in the back. My question is about data availability. When you look at the examples you just shared, where that data is available, whether it's Kenya, Uganda, Zimbabwe, Zambia, and so on, there is a strong presence of IMF and the World Bank. There's a strong presence of other factors in terms of open up your books, open up your hospitals, give us access to your patients and let us monitor and things like that as a condition to these other things, as opposed to, say, the North, where society might be a little bit more resistant to that. What's your comment on that?
Well, actually, almost every country in the developing world now has had a demographic and health survey. So I don't really think that it's connected up much with either the World Bank or the IMF. I mean, both organizations, I think, have a lot to answer to or answer for, but I don't think that these demographic and health surveys, if you're here and you're not a senior and you're thinking about writing papers, are publicly available. You have to apply online, which takes about 60 seconds, but then anyone can download and use those data. But I think that it hasn't really been about World Bank or IMF. And I think that like the wealthy countries have long had vital registration systems that allowed governments to actually have a sense of how many of us are there and how long are we living and how well are we living with what kind of comorbidities. So, and some of my friends are very talented in getting those governments to actually let them in a way that's doesn't bring the identities of individuals out. Use some of those data to analyze what's happened in Norway in the whole sweep of the 20th century, say. So the North has always, because it's been wealthy for so long, has been in the data collection business for a very long time. But for me, one of the things, when I started my professional career, there were almost no data on what was happening in Africa, right? So the idea that if you wanted to actually say something that might help, good luck to you, because that just wasn't on. So this was really, I want to be careful about what I'm saying because I know this is being taped, but these demographic and health surveys started because people were worried about population control. And so the questions were really rich in terms of contraception and like 100 questions on contraception. Now they're becoming much more useful for us for people who are worried about, for example, HIV and about kids getting to school. Right? Now they're actually things that you can use to try to talk about more than just reproductive health, but branch out into other things as well. So for a lot of us, those have just been incredibly important in terms of trying to either compare across countries or look within a country over time. Yes?
Can you comment on her comment about success in Uganda?
Oh, very good. Yes, I mean, part of what made it work in Uganda was that there was this very, as I understand it from Helen Epstein's book, I'm not an expert in Uganda, and I've never worked in Uganda, but In Helen Epstein's book, The Invisible Cure, she highlights Uganda as a place where there was civil society that helped make that work, that there were networks of women that helped make that work. And so that while that may work in Uganda, that may not work as well in other parts of Africa, given that they don't have that same history of civil society playing as an important role as it happened in Uganda, where this policy of what they called zero grazing, which means pull back on your casual partnerships, really seemed to take hold. So that's, thank you. Okay, thank you. Thank you.
So on behalf of the university, I'd like to thank Professor Case for a very insightful and stimulating lecture. Thank you. For the ODE dinner guests, again, the reception is over in 4:05. Thank you.